Hello, and a very good afternoon to all our viewers to this Master Series session. Today, we will be talking about managing psychotic episodes in a general practice setting. Chronic relapsing psychosis have severe implications on the quality of life of patients and their families. Usually, a general practitioner is the first contact when severe disturbing symptoms occur. Patients with severe psychotic symptoms often cannot interpret physical signs and care for themselves. The general practitioners, therefore, have an increased responsibility of providing easy access to care for such patients. To discuss more on this topic of managing psychotic episodes in a general practice setting, we have with us today Dr. R. Padmavati. Dr. R. Padmavati has over 33 years of experience in psychiatry, community, child and adolescent mental health, and physical health in persons with mental illnesses. Dr. Padmavati has received several awards, including the Young Woman Scientist Award for the year 2000 from the Government of Tamil Nadu and the Indian Psychiatric Society Marfatia Award for the paper entitled Structural Brain Differences Between Never Treated Schizophrenia Patients with and without dyskinesia and normal control subjects in 2001. It's an honor to have you with us today, ma'am. Over to you. You may please share your screen and begin your presentation. Ma'am, you're on mute.
Yeah. Thank you very much, Dr. Patak, for inviting me to be part of this program. Um, Good afternoon to you, viewers, and it's with great pleasure that I'm presenting today in front of you on a topic that's something that I've been working with for many, many years now. Give me, um, yeah. So I'd like to begin with, trying to with telling you why I actually chose this topic. In fact, I must thank doctors for giving me this opportunity for talking about psychotic episodes in general practice. Because as Dr. Patak has already, in her introduction, said that often people with psychosis, the first point of contact is the general practitioner. And the general practitioner is in a position where you can really do a lot to one, reassure the person with psychotic episode and reassure the family because perhaps you've known them for several decades. What I'm going to actually run through today is tell you a little bit about what is psychosis. I will, move into a little bit of theoretical framework on this whole subject of psychosis. Maybe, I can take questions anytime, you feel like interrupting me. I will definitely talk about presentations of psychosis as they would come to you, early signs and symptoms of the problem, and how do you manage them. And of course, I will end with a little bit on impact of the psychosis. When you look at what is psychosis, I'm sure in our MBBS, you would have at least the little bit that we do in psychiatry at the level of the MBBS. We know that psychosis refers to a group of conditions that are classified as severe mental disorders. They're characterized by a change in behavior, in thinking, in emotions. And the very key important thing is there's loss of touch with reality. Many of our patients have no insight into their problems and don't accept that they have a problem. Uh, Naturally, the signs and symptoms are such that their work is impaired, and over a period of time, it does cause disabilities in different areas of life. When you look at how frequent is this is one of those low frequency kind of conditions. When you compare it to NCDs or NCDs like diabetes or even infectious diseases like tuberculosis, and we find that there are not very many people. Uh, if you look at pure numbers, right? If you look at about 100,000 youth or young adults, there would be only about 274 young people with this kind of a problem. It may be small, but it is extremely disabling. In fact, a condition like schizophrenia is often called a cancer of the youth, right? So, a 1 year prevalence of non organic psychosis in the community is about 4.5 per thousand. And this has been repeatedly established over decades of research. The commonest age for presentation for men is less than 30. In women, it's about less than 35. And you'll also see a lot of it occurring in people over 60 years of age. Schizophrenia itself has a prevalence of 3.3 per thousand and a lifetime morbidity of 7.2. When we say lifetime, it means the number of relapses that happen over a course of the age of the individual. So overall, psychotic symptoms have about a 10% prevalence in the non-demented community over 85 years. So let's try and understand why this happens. Going into the etiology, um, when you're looking at classification, when you look at mental conditions, right, as against medical conditions, psychosis can happen in people who have psychiatric disorders. It can also occur in many general medical conditions, and of course, people who use substances, alcohol, for example, you do get a number of people who present with psychotic symptoms. The risk factors, as in many other NCDs, are genetics and environmental vulnerability, usually a combination of both. And we do have a number of brain theories. We talk about dopamine, we talk about glutamate, we talk about serotonin, and all this is work in progress. And I'm sure over time, more number of neurotransmitters will appear to play a role in the emergence of psychosis. So what are the psychological conditions which presents with psychosis? You have schizophrenia, bipolar disorder. In very severe stress conditions, also people can report hallucinations and delusions, severe depression, and very simply, when there's lack of sleep over a period of time, people can present with psychotic symptoms. And if you look at the list of general medical conditions, that is the organic conditions, you will find that a number of conditions have been listed out. And I'm sure you're aware of many of these conditions: endocrine, metabolic, nutritional deficiencies. In all these conditions, people can present with psychotic symptoms. And again, there are a number of substances which can some of the symptomatology will be psychotic symptoms, and when people have either overdosed on this or on regular use of these substances. When you look at the risk factor, what adds up to psychosis is that, see, when you find that there are people with some kind of some kind of genetic issues maybe there. For example, you'll find family history, you'll find twin studies, which I'll go into in a bit of in a little later. So the issue here is that, when you have people, people who are unaffected. That means there is no genetic overload at all. But then the same kind of people, that when it is combined with environmental stress factors, the problems can actually multiply, and you find that psychosis can manifest. So what is the evidence that there could be a strong genetic basis for these psychotic conditions? There are many family studies which show that psychosis runs in families. That means multiple generations can present with this kind of a disorder. This, of course, also does not mean that every family where there is a history of psychosis, the next generation will have schizophrenia or bipolar or whatever. But we do find that in a number of cases, you need to ask this question: did anybody in your family, particularly the first degree, have a history of some kind of mental illnesses? We also found that, number of twins, when you look, when there are identical twins, when one of the identical twin has a psychosis, there is enough evidence to show that the other will develop the same illness in a short while of there's very low prevalence of psychosis developing in the twin when there are non-identical twins. Number of adoption studies have been done where, even if you remove one twin, remove the person away from a psychotic environment, you do find that they can still develop uh, they can still develop psychosis. But then usually environmental vulnerability factors are also needed. When we look at what are these environmental vulnerability factors, see, what we talk about in conditions like schizophrenia is a vulnerability hypothesis, where we say that what is inherited is the vulnerability and not specifically the gene, right? Of course, in recent studies we have demonstrated that there are specific genes which can actually cause this problem, but it's not really a very large sample that has been studied, and therefore you cannot generalize those findings. Number of people have worked on number of hypotheses, like difficult labor, living in an urban area, living in a crowded urban area, migrating to other places. When there is a childhood history of head injury, childhood trauma, that again is gaining a lot of ground. And childhood trauma includes not just sexual abuse in childhood, but also even trauma of, say, for example, young children have actually reported, and young children with first episode of psychosis have actually reported that, the school teacher has been very strict, or they have been writing too much of homework. And this is again looked at as a kind of a traumatic experience. Then, of course, everybody talks about stress, and drug or cannabis use in particular definitely is seen as an environmental vulnerability factor. Then I did mention, I'm not going to go into great detail, but there are a number of theories which says that because there is a neurotransmitter default in the brain, the reason in which in certain parts of the brain, this is why you get people to experience psychotic symptoms. And some of the conditions which they have explored are things like auditory hallucinations, looked at obsessive compulsive disorders, and sometimes even delusions, which have been explained on the basis of these neurotransmitter theories. Now let's move on to what are the key main symptoms of a psychotic episode. You have a group of symptoms which are called positive symptoms, where people report on delusions, which is a false fixed belief, hallucinations, and thought disorder. Then there is another important clinical area which is called as negative symptoms. Essentially, it means what is not there. For example, if the person is not functioning adequately, not going to school, not able to concentrate, a homemaker is not able to cook, not able to socialize, these are some things that we call as negative symptoms, and they are actually a big challenge in the field of management of psychotic condition. As I already told you, delusion is a false, fixed belief, unshakable belief, and it's not in keeping with the person's cultural, educational, and social background. You have hallucinations, a sensory perception, and it can happen in any of the sense organs, but auditory hallucinations are most common. Then you also have visual hallucinations and olfactory, which are quite common. One other important area I'd like to bring to your attention is about the prodrome, which is a definable period before the onset of psychotic symptoms, during which the functioning becomes impaired, but the individual does not really present with acute psychotic symptoms. I'd just like to, briefly tell you the story of a young girl that I saw her first in the month of, it must have been, I think it was about March of this year. Just before her school examination, her father brought her to the clinic, and he said that, she's extremely anxious. She does not want, she says she cannot study. We did a detailed examination. We, tried to get history out of her, but there was absolutely no history to indicate any psychotic symptomatology that she present. But there was a lot of anxiety in that girl. She was put on medication because she was also very depressed. She was a girl who was, extremely, uh, she called herself an extrovert. She was good in art forms, dance, music, and also was doing academically very well. And she actually is a young Punjabi girl who had moved to Chennai. But she had moved to Chennai when she was a little baby. And so it's really not migration that had caused the problem. And she's been living in Chennai for the best part of her life. And she presented with anxiety. The anxiety kind of settled down with medications for a bit of time. She took her health exams and went off to Amritsar to, be with her grandparents in sometime during the summer vacation. But at that time, the father also noticed that there were other symptoms that were cropping up. And what he did was, the symptoms were like, she would suddenly wake up in the middle of the night screaming, and she would go into periods where she actually had loss of consciousness. So the father promptly took her to a neurologist, and she was thoroughly examined out there. They said they couldn't find anything, but then did put her, maybe they were thinking in terms of a kind of a, aborted seizure, which they put her on some medications, but she refused to take those because they were making her very drowsy and she didn't want to really take. Then he, of course, did things like take her abroad for a vacation, and everything seemed to be fine. She joined back school in June. Promptly in the third week of June, he reported to me back from. At this time, he had actually decided at that time to move to Amritsar, and so he put he admitted her into a school there. And there, for the first time, she said, "I think the teacher is against me. The teacher does not like me because I'm a. The teacher's calling me a Madrasi. Madrasi means somebody referred to from Chennai, but the usually when somebody talks about being a Madrasi to a person from Tamil Nadu, it's taken as an offense, right? So this young girl also decided that, being she's being insulted by the teacher. And this went on for some time. Father reassured her, nothing happened. Then he brought her back to Chennai for a review. Brought her back for psychiatric examination. And at that time, we found that she was also presenting with symptoms like hallucinations. She had very clear auditory hallucinations and visual hallucinations. So the prodrome, the period in which March it started with anxiety, but it went on to develop into a full blown psychotic episode in the month of June. So this prodrome was very, very important period. And I think I'd like to bring it to the attention of the general practitioner here, because that's the time we need to, make sure that the girl, the important thing here was that we identified the psychosis early and we started treating her. Today, the girl is much better, back to school in Amritsar. So, as I told you already, the early signs in so the prodrome is an important period. But what happens after the prodrome is that as they progress, there are a lot of other symptoms that you need to pay attention to, like anxiety, depression, sleep changes, vague doubts and suspicions, concentration difficulties, being a little aloof and withdrawn, and coming up with some unusual thoughts or beliefs, right? Once they go into a full blown psychosis with delusions, hallucinations, speech disturbances, suicidal thoughts, and so on, the picture is very clear cut. But the early stages are very, very critical. Uh, but once when psychosis happens, then you see that uh, uh, this chart actually goes to tell you that the initial prodrome state, which is symptom driven early detection, is perhaps key. And I'll move on to explaining what blips are, what APS are in a bit. But then it just moves on to developing a psychotic kind of a phenomenon, which then goes on to becoming a full characteristic episode of psychosis, which we would now call as the first episode of psychosis. This is a story of a young male, 15-year-old studying in Standard 10, high achiever. Uh, Again, the complaint was he did not want to go to school. Suddenly, I mean, he just, for 1 week, he said, don't want to go to school. He was not eating properly. He was having very poor appetite. All this the mother noticed as a sudden onset, and the duration was about 1 week. Naturally, the worried mother goes to meet the doctor uncle with the kid. The doctor uncle here was the family doctor who has known the kid right from when he was a little baby. The doctor notices that there's something wrong with this kid because he has known the kid over 15 years. So he notices that there was something wrong and he starts probing. They then realized that the drop was not just about a week. In over 4 to 5 months, this child has not been doing well academically. Child has not been his usual self, not playing around, and so on. And the doctor was quite perceptive. He noticed some psychotic symptoms, but was not very clear. That was when he referred them to a psychiatric clinic, and the kid received treatment. So when we are here looking at a concept which is called ultra high risk. Now, a ultra high risk first criteria to meet the UHR criteria, the patients must have, definitely two symptoms. They must have one of the two symptoms. One is a 30% drop in functioning from a pre-morbid level, and this has to be sustained over 1 month, occurring within the past 12 months, right? So that must be there. And the narrative that I gave you earlier actually fulfilled this 30% drop. Then over the past 12 months, this person should have a chronically low functioning, or I mean 12 months or longer, and meet the criteria of one of the following below. That is, there should be a family history of psychosis in the first degree relative, or something we call as a schizotypal personality disorder. Uh, Second group would be attenuated psychosis. I mean, we have our own standards for examination, which I'm not going to go into. But what happens is there is psychotic symptoms, but the intensity is very low. Like in this earlier case that I told you, the doctor had a suspicion, but he was not sure if there was a positive psychotic symptoms. Symptoms along with the decline should be present for at least 1 year. Then there's another challenging group which is called the blips, or the brief limited intermittent psychosis syndrome, where the person who has experienced episodes of frank psychotic symptoms within the past 1 year that have lasted only for about a week or so. So many a times it's very difficult to get this history, which has lasted only for about a week or so. But with little bit of gentle probing, we are able to get that history. But remember, it has to be there for the past 1 year. So our friend, 15-year-old friend from the earlier case vignette that I presented, actually presented only with a would we would act, he wouldn't actually go to meet with the attenuated psychosis. Maybe we can call him in a kind of vulnerability group. In fact, he did have a family history of psychosis in a grandparent, not the first degree, but in a grandparent. Moving on to another case vignette. S is a bright 17-year-old doing her first year in engineering. Few months into the course, she refused to go to the college, giving no reasons at all. And when her family insisted that she had to go to college, she actually locked herself inside the room and cried for hours. She actually even threatened suicide. She had not slept for a long time. She would not eat food. She stopped communicating to her family. She also started neglecting her hygiene. And now the family also noticed that she was muttering and smiling to herself all the time at some points. She was again brought to a psychiatric facility. And on inquiry, we found that everyone at college, she said that everybody in the college was talking badly about her. And that is why she didn't want to go. She also said that you could hear them saying things even when she was at home. That made her stay in her room and not get out of her home, to get out of the room to meet other people. And she said, she was very sure that somebody in the college did not like her and had orchestrated these comments. This is what we would call as first episode of psychosis. In people ultimately diagnosed with schizophrenia or bipolar, the first episode often occurs between the age of 15 to 30. Now, it's very important for us to identify this person early, because we have proved that, providing them with care very early in the illness actually leads to better outcomes. In fact, in a study that we have done at SCARF, only 3 months of antipsychotic medications were given. But the 12-month outcome indicated that most of these young people were actually pretty well. So they only required regular contact with the psychologist, but the treatment per se with antipsychotics actually stopped within 3 months of onset of the psychosis. We must remember that there's a big gap. We call it by the term duration of untreated psychosis. There's usually a big gap between the first presentation of the symptoms and the diagnosis of the episode of psychosis, which actually leads to treatment delays. The longer the DUP, the worse is the outcome. Um, so, I mean, we found that the a period between the first onset of psychotic symptoms and treatment has been reported to be over a year in our country, and this has been a finding that's been replicated over several decades, which really means that a lot of work has to happen for people to get educated about this psychosis. And we believe that the general practitioner is one person who can actually identify this very early and direct the treatment. And why should we do that? We have found that treatment actually works, and like I said, remission happens often within the first 3 months, and people can actually be pulled out of medications even that early. Uh, so, what are the common signs of emerging psychosis? We've already talked a lot about performance in school, work, family life, etc. There could be a lot of young people spending time alone, doing or saying things that seem very bizarre and strange, and nobody can understand what they are actually doing. Many kids present with depression, irritability, social withdrawal, hostility, decline. I mean, anything, any one of these symptoms can actually be present. And I would think the element of suspicion for making a diagnosis could be one or more than one. That is the sensitivity of these symptoms. So, what do we do once we make a diagnosis? There are a range of antipsychotic medications. I mean, there's been a lot of global debate on whether you use antipsychotics for these young people, because many of them are sometimes less than 18 years old, cannot consent to taking medications. But then there's also a lot of literature which has talked about using of these molecules in the early part of the illness and actually stopping them after a period of time. So you have the first generation antipsychotic medications, you have the second generation antipsychotic medications, and all these are tried and tested over time. We've also found that not one molecule is not much better than the other. So it is left to the clinician, the psychiatrist's choice for what they want to use it. In India, the commonly used drugs for the first generation antipsychotics is about haloperidol, chlorpromazine. The other, in the second generations, we tend to use aripiprazole, olanzapine, and risperidone as the common first line of management. In SCARF, we actually have a first episode psychosis program, and this is the only dedicated program for FEP in South Asia. So, what is offered here is a rapid assessment and initiation of treatment, dedicated case management, integrated family and individual psychoeducation, individual need-based psychotherapy, and of course, a very important thing is the continuous follow-up. So, what is the GP's role? I think the most important role that you can do is recognize these early symptoms of either prodrome or early psychosis, recognize it early and actually, refer them to the mental health professionals as soon as possible. Once a diagnosis is made, many of our patients, many of our families actually go back to the doctor to check whether, doctor, should I really take this medication? Should I really, support? Do you think it's okay for me to take the psychiatric medication? I think it's very important to you that you offer the support to the family, because remember, we as mental health professionals are often stigmatized, if I can use the word, and I will explain why I'm saying this. And the support for the family and the young person should actually come from the general practitioner. And I think it's also very important for the GP to maintain a connect with the treating psychiatrist. And there are several important reasons for this. One is to ensure continuity of medications till the psychiatrist says so. And secondly, when the person has, when there are a lot of questions that the family tends to ask, sometimes it might be useful to run it past through the psychiatrist before you can actually respond. I would like at this point to share a small story about what happened in such a context. We at SCARF have a very healthy connect with many of general practitioners around. And it so happened that, once a similar story, first episode of Psychosis, the young girl, it was a young girl, I remember. And this young girl, the family goes back to the general practitioner, and the general practitioner is very, supportive to them. He is very encouraging for them to take the medication. He is on a good liaison with the psychiatrist, and together they decide that the patient's medications have to be stopped. Now one other thing, so several years pass by, about 2 3 years pass by, and one day the mother comes and tells the doctor that this they've actually got this young girl. When she turned 21, they actually got her married. And she tells the general practitioner that, hey, you know what, after she got married, I'm seeing that there are similar problems that happened 4 years ago. The general practitioner very humorously actually came and said, you know what, just because I'm your friend, I'm also never got invited to that marriage, because he knows that psychiatrists are usually not invited to such gatherings. And he said, just because I'm a friend of yours, I also did not get invited to that marriage. But he was actually very upset, because he felt that had he known that this girl was going to get married, he might have actually connected with the psychiatrist and perhaps offered some psychological support to this young girl who was entering into a new sphere of her life. So that's where a GP's role comes through. Then, through the course of the illness, the general practitioner can be very, very important for early recognition of early signs and symptoms of relapse. We have a number of general practitioners who actually administer the depot injections, which are a very important therapeutic pharmacological agent in the management of chronic psychosis. And of course, managing the side effects efficiently without stopping the antipsychotics is something that a GP can do. I'd like to end by just giving you a little bit of how do you talk to a person with psychosis. One of the important things that even we as psychiatrists are trained in when we are doing our postgraduate training is, we are told, do not pretend you understand the patient's words or meanings when you are confused. Tell the person that you are having a difficulty in understanding when they talk about hallucinations, when they talk about delusions, and so on. Place the difficulty of understanding upon yourself. Said, I have trouble following what you're saying, and do not use terms like you are not making any sense. Tell the person what to do, what to understand, and reinforce clear communication. Keep their anxiety down by using a low tone, calm voice, and a firm direction. Thank you for listening. And now I'm happy to take any questions that you might have.
Thank you so much for that very detailed presentation, Dr. Padmavati. We do have from the audience like
Dr. Manisha, I'm not sure if it's you or me, but your
you
voice is
if you could
breaking.
kindly just provide a brief summary. Now, ma'am.
Yeah, I think it's a bit better. Yeah.
Ma'am, the first question that we have for you is, what are the risk factors for psychotic disorders?
Yeah. I've actually addressed this in my presentation. It is a combination of a gene plus environment kind of vulnerability, gene plus environment that actually contributes to psychosis in most conditions. In almost all conditions, you can establish some kind of a genetic connect, right? And normally what we say is, what is inherited, what is a is a risk vulnerability to develop psychotic illness, just like how you would say vulnerability to develop diabetes or cardiac issues. In the same manner, we talk about vulnerability to develop psychotic illness. Again, as I told you earlier, no single gene has been isolated. We are working on it. There is some clue as to what is the gene that's been created, but this is again on very, very small sample size, so we cannot generalize used on this. So today, what we know is that it is a gene plus the environment that is responsible. The gene can perhaps contribute to the neurotransmitter dysfunction, or it could come, which is really creating the vulnerability to develop the disorder. And the environment is a mix of a whole lot of things, including things like poverty, living in a crowded area, having a family environment that could be toxic, alcohol use in parents, and so on. So these are the two important criteria that are risk factors to developing a psychotic illness.
Right. Thank you for that response, ma'am. Ma'am, any take-home message for our general practitioners in terms of diagnosing or managing patients requiring psychiatric treatment better in their
Yeah,
routine clinical practice?
right. I mean, I did spend a lot of time looking at the first episode of Psychosis. I've always believed that, if you are aware that, hey, there could be some problem, that should raise the antennae, and make sure that you either probe for more psychotic illnesses, or make sure you refer to your closest psychiatrist, who's a closest friend who's a psychiatrist, right? That's what I would say. We really want to be friends with the general practitioner, because that's the only way we can access these young people faster. This is one thing, that is, there must be a lot of awareness amongst you, and which is why I insisted that Doc Plus gets this program on, because psychosis is not often a talked about subject as much as depression or anxiety is. The other important thing which I did not mention during my presentation is the role that the general practitioner can play in dealing with non-communicable diseases of the person with psychosis. One of the things is that people with psychosis die 15 years earlier, and the single important cause for mortality is cardiometabolic conditions. People with psychosis often don't report a chest pain, or they don't report uh, their dietary habits can be actually haywire, a lot of carbohydrate consumptions and so on, and which means that diabetes is quite common. The another important reason is the medications that we prescribe. In all the antipsychotics do cause an increase in the blood glucose level, and together they can be a very formidable condition which can cause mortality. The general practitioner is the one who's like readily accessible for treatment of hypertension, cardiovascular risk, treatment of diabetes, and so on. And I think at that stage, if you can manage the conditions without altering the antipsychotics, it'll be a boon for the person with psychosis. And I can tell you, because of my interest in cardiometabolic conditions, I've been working with a number of physicians, internal medicine, general practitioners, to actually make sure that the diabetes is under control, the cardiac monitoring is done frequently as is per the guidelines, as per prescribed guidelines, and we are able to improve quality of life of the individuals who are under treatment for psychosis. So that's something which I really think one of the knows. I've told you, shared some good stories of how the general practitioners have actually been very been in partnership with the mental health professional. But I must also share some not so good stories, because I think we just need to become aware of these situations. I've had general practitioners who have told young people, don't take these psychiatric medications, right? They're not good for you. Once you go to a psychiatrist, you'll be on the medications for the rest of your life. And all these myths, right? Coming from a general practitioner, the families accept it very easily. Definitely not from a mental health professional, because they've not seen us before. They're seeing us for the first time. So the general practitioner is the one who has to have a bit of a curiosity and find out exactly why the antipsychotic was prescribed. And that's why I think you should maintain contact with the psychiatrist. And most psychiatrists share their numbers with the patients, because we are always worried about side effects. We're worried about you know potential suicidal attempts and so on. So I'm sure they will share the number with the contact with you as well. And as general practitioners, it might be good for you to have that connect with the treating psychiatrist, because together, as I said earlier, together we can certainly do a lot for improving the quality of life of our patients. Yeah.
Right. Thank you. Thank you so much for that very detailed response, ma'am. I'm sure a lot of physicians on our platform, general practitioners, would have learned or gained a lot of insights from your presentation and your talk today. And hopefully it'll lead them to diagnosing, identifying, and managing patients with psychosis in a much better manner. Thank you so much for your
Thank
time
you.
and for making time for
Thank
this
you.
presentation. It was very insightful. To all audience members, thank you so much for being a part of today's Master Series session. We will be back with another clinically relevant talk next week. Until then, please take care and happy doc flexing. Thank you so much, ma'am.
Thank you. Thank you so much. Yeah.